Very good.
It says we're live.
It says we're live. Great.
It says we're live. Good evening, everyone. Welcome to Back to Basics. We're really excited to have you guys on. I am excited to see you guys all chipping in and very interested in this topic this month. May is asthma and allergy, of course, food allergy. We're talking about food reactions Awareness Month. My name is Dr. Vivian Asamoah. I'm a functional gastroenterologist in Katy, Texas. And we are excited and honored tonight to have Dr. Brent Dorval with us. Dr. Dorval, I want you guys to learn a little bit about him. He has over 35 years experience in strategic management of research, manufacturing, and regulatory affairs in the areas of medical devices and diagnostics. Previously held a number of management positions and served as an advisor to the World Health Organization Committee on Vaccines and Diagnostics. Dr. Dorval has several patents covering rapid assays, novel biomarkers, and a novel polio virus vaccine. Dr. Dorval holds a PhD in medical microbiology and immunology from the College of Medicine, The Ohio State University, and performed postdoctoral studies and was a visiting scholar in the Department of Chemistry at Massachusetts Institute of Technology. Welcome to Back to Basics. We are excited to have you on, Dr. Dorval.
Well, it's a pleasure, Dr. Asamoah. It's a nice night here in Massachusetts, and I hope it's equally as nice for everybody in the audience. We finally turned the corner here. But it's a pleasure to be speaking tonight about food sensitivity.
Excellent. Wonderful. So we started talking about food sensitivity this month as part of our May awareness for food allergies. And we kind of dove into the topic of food reactions, distinguishing between true food allergies, immune-mediated IgE food allergies, and then where we see a lot of patients focus their attention is on food sensitivity. So IgG-mediated food sensitivities. And this is where we thought it would be wonderful to have you on so we could learn a little bit more. We use the KBMO fit test at our practice very often. We found quite a bit of benefit in using it, but we want to make sure we're using it the right way. So Dr. Dorval is Chief Scientific Officer with KBMO Diagnostics, which is probably one of the top, food sensitivity labs that I have looked at and researched into. We have some good publications from them. So it's very interesting. It's great to get the information right from the lab. Yeah.
Thank you.
You're welcome. You're welcome. So I had a couple questions for you, and I would like to just start off, just launch in, and we would love for people to ask questions as we go along. But let me go ahead and ask first and foremost, how do food sensitivities differ to food allergies?
Okay, very, very good question. So true food allergies, as you alluded to, they're type 1 mediated reactions, and they're generated by IgE antibodies. So IgE, and they're immediate. And generally, those are the ones, and the example would be where a person would eat a peanut, they'd go into anaphylactic shock, and that's as a result of antibodies that had been produced in the past, and they would need epinephrine or some other medication to make sure they don't go into anaphylaxis. Now, what we're dealing with in food sensitivities are type 2 and types 3. So those are delayed reactivities to foods or additives or other types of compounds that you may have consumed in one way or another. And they're mediated by IgG 1 through 4. So 4 subclasses of IgG, and through immune complexes that activate complement or C3d. So there's an important distinction there. So you have not only antibody involved, but you have a complement reaction, which essentially generates the inflammation, which is associated with immune complexes.
I see. I see. I see. Could you tell us a little bit more about this immune complex? Because I believe this is what makes the FIT test a little bit different to other food sensitivity tests. How important is it to detect this immune complex? What does it signify?
Yes. Okay. Well, there are basically there's three basic types of tests that are out there right now.
Mm-hmm.
There's the IgG only test. They
Mm-hmm.
measure IgG 1 through 4.
Mm-hmm.
There are cellular tests out there that look at cellular morphology. Cells shrink, cells swell,
Mm-hmm.
and the claim is made that if the change in morphology occurs due to exposure to an antigen, a food antigen, or an additive, that the result is they're producing or going to produce cytokines, something like a IL-6 or a TNF-alpha, which causes inflammation. Although they're never directly measured, the cellular tests are very indirect. Now, contrast that with the KBMO FIT test. Mm-hmm. We measure both IgG 1 through 4 mm-hmm. and the flag marker or the marker for complement activation, C3D. So what we do is IgG is produced mm-hmm. and it binds to a food antigen and it forms an immune complex. Mm-hmm. When that happens, it activates complement, and then C3D is deposited on the immune complex and is bound. And in the process, mm-hmm. a molecule C3A is generated, which causes intense inflammation. What's important to remember about KBMO is it measures both the innate immune system, which is the complement system, as well as the acquired, which is antibody. So the IgG only test only measure acquired immunity, that is the response to an antigen. And where that becomes important is that if you measure the inflammatory component, what you get is a much more accurate estimation of those foods that potentially can cause inflammation. And I think, as we all know, inflammation is really the cornerstone of all the symptomology, or certainly most of it, that doctors and clinicians see in their practices. So, absolutely. So it measures innate and acquired, whereas the other test measures only a single pathway, the acquired.
Okay, Dr. Dorval, that's a lot of information right there. That's a lot of information coming from a PhD scientist. Let's break this down a little bit more. Okay. Yes. Whenever we talk about that acquired your response, right? Yes. That means whenever we ingest anything, we do have an acquired response to most foods that we ingest, right? Is that correct? When we eat something, it presents as an antigen, and the acquired response is developing that IgG antibody to that food, which doesn't necessarily mean that there is an immune activation from it. There's inflammation driven from it. Is that correct? Yeah. What happens in those people that have food sensitivities and the symptomology associated with food sensitivities is you ingest an antigen, a food that presents itself as antigens. It's broken down to a greater or lesser extent in the gut. Those food antigens then go through the gut wall. Generally, you have leaky gut. So you have some penetration of that antigen through the gut mucosa. It enters the Peyer's patches. And that's just a way of saying that's the lymph nodes. The lymph nodes then have B cells. And those are cells that say, oh, I recognize that antigen. Now I'm going to start to produce an antibody against that antigen and try to clear it from the body, because those antigens should be going through the gut and excreted normally. They should not be getting through the gut wall and generating antibodies. The real issue is when you get the antibody being produced and it binds to the antigen, you get the activation of complement and then the generation of the inflammation that's associated with
a wide variety of symptoms, whether it's a headache, IBS, a vasculitis, a wide variety of things.
So I definitely see that. I mean, from from the bench to the clinical translation of that, the importance of that immune complex in identifying that inflammation that is occurring from that food. So that's really important. So question for you, if someone does not have any symptoms at all, they feel great, they feel healthy, would you advise a food sensitivity test or not?
Well, that's a really interesting question. These days, there are really two classes of patients that we see, and we see those that really have some sort of symptomology that's associated with food sensitivities. It may be anxiety, it may be depression, it may be, again, irritable bowel is a big one, skin disorders, etc. Then you have another group of people that say, well, I really don't feel bad, but I want, they're more in the, no, I don't want to say health fanatics, but certainly they're health conscious. And they say, I want to improve my performance, whether it's professional athletes that we've tested or other people generally that just want to say, okay, I want to check my status. I'm curious. I'm health conscious. I eat health foods and I want to maximize performance. So it really, is an interesting mix of patients these days.
It is. It truly is. It truly is. But you're still not telling me whether you would advise someone who does not have symptoms at all.
Yeah.
That's their decision at the end of the day, if they want to test or not test, right? But what would you expect to find in someone who has zero symptoms?
I would not recommend, as a general rule, testing that individual. No. I mean, it's like anything. Sorry, I didn't be more direct. I would not recommend it, even though I work for KBMO. I would not recommend the thing.
Right. So I know that. Let's go back to the technique that KBMO uses, because I think this is one of the reasons I was drawn particularly to this lab, and I've gotten great results. But some labs are checking for raw foods versus cooked foods. Can you tell us a little bit about sort of the antigenic presentation, what that means? What is the relevance of that?
Right. I mean, there's been some discussion of that in the literature and some papers produced around that particular notion. I mean, raw means you have native antigens, and cooked simply means when you cook things, the proteins are denatured, so it changes the configuration. So in a traditional sense, that's what that means. What we do on the FIT test is we not only manufacture our kits, we use them in the clinical labs. But having said that, in manufacturing, what we do is we produce the antigens in such a way that we have natural antigens and then we have some denatured antigens, so that we have a mixture of both, and we put those on the plate for each individual food that we're testing. So it's kind of a mix of two. But having said that, this cooked versus raw is more academic interest, I feel, than anything else. Because where the rubber hits the road is what happens clinically when you test patients. And when you use the KBMO test, what we've demonstrated with the KBMO test is that you have a significant reduction in food sensitivities and symptoms based on the results from that test. And that's a clinical study that was done on 30 patients in a retrospective way. And then when we looked at irritable bowel and we tested patients before and after, what we found is that if patients followed the diet that was indicated by the testing of the FIT test, that they improved significantly better than if you did the same thing with a cellular test or with an IgG only test. So I say clinical results really trump what some of these scientific papers may indicate.
Understood. So I understand that when you have a food sensitivity, your reactions may be delayed. It may take up to 21 to 23 days to actually notice, right, a reaction from that food. So when you do identify these foods that are in that high sensitivity zone, in that red zone, right? on a KBMO fit test, how long would you suggest they avoid the food for? Because I'll tell you, and sometimes I've seen, patients come to me in our functional gastro program and they're like, I haven't been eating these foods for like 6 months and I only eat 3 foods and I only eat, so how long do we keep them restricted, like on that avoidance protocol for? And then when is it safe to start reintroducing?
Yeah, another very, very pertinent question. So what I would recommend, 4+ would be the high red category on the fit test. I think many people have probably seen the bar graphs that in the test, the actual test. So what we would recommend there is at least 8 weeks. And here's why. Because antibodies have a half-life. That means half of it will go away in 21 days.
Right.
So that in 3 weeks, 6 weeks, you have 2 half-lives and then half-life and a half. So I don't want to get too technical here, but the idea is to go the longer 8 weeks. Some practitioners will say even 12, but 8 weeks, the antibody goes down, antibody titer, then reintroduce the food, let's say on Monday, and then ask the patient or the practitioner, monitor the symptoms Monday, Tuesday, Wednesday, Thursday. And if the patient says, oh my God, I had it, and by Tuesday, my headaches came back or my bowel problems came back, you can pretty well rest assured that that's a trigger food and it causes some symptoms. Then repeat it one more time the following week, just to be sure that you've got a trigger food. And then longer term, I would say if that occurs, have the patient abstain from that food for 6, 8, even 10 months.
Right.
Yeah. And during that time, because with food sensitivities, irritable bowel is very often associated and tight junctions are open. So you want the gut to heal.
Yes.
Zonulin generally is very high. That's a test that we offer as well. So you want the gut to heal. You want the immune system to quiet down. You can reintroduce that antigen, say again on a Monday, 10 months later. And the patient may say, geez, I ate it on Monday. I felt fine Monday, Tuesday, Wednesday. Do it again. Fine. So that patient, what I would say is now rotate that food in the diet. Don't eat it every single day or frequently, because most assuredly that sensitivity will come back. Now, there's a separate group of patients where after 10 months, they may eat it on Monday, and Tuesday morning they say, guess what? My symptoms are back and I feel just as bad as if I never abstained at all. And I think there's a genetic component to this, much like celiac disease, where if you have certain alleles, the 2 or the 8 allele, the D2, 2 or 8, you got a predisposition, and genetics will trump no matter what the diet does. So I think in some ways, genetics is involved in this as well for some patients.
That's most likely true. That's most likely true. It's unfortunate that we don't have all the information that we need in terms of SNPs and identifying which patients would be sensitive to what types of foods. But for the most part, Doc, you've been doing this for a long time. You work with a lot of clinicians and consult, all around the world. What do you think are some of the top causes of food sensitivities today? What do you see as being some of the root cause as to why this person has a food sensitivity?
Well, I've thought of that, and I've talked with a lot of people about that. And I think in many ways, food processing, the way we process foods today,
absolutely.
I can't help, because just over the past few years, there's been a 50% increase in adult and children food sensitivities and also allergies.
Allergies as well, yes.
So, food is the link. The question is why? And I think a lot of food additives, whether they're colorants, whether they're things like BHA, BHT, which are chemicals that are put in there as preservatives, or MSG, a flavor enhancer. I think these things interact with the foods in such a way to change them. And then your body says, well, I don't recognize this, meaning it's foreign. Now I'm going to generate an antibody. So I think if I had to say one thing, food processing, I think, is a major factor. And then secondarily, I think GMO foods in some way, I don't want to slam. I mean, on one hand, you can produce an abundance of food for the world, and that's a great thing. On the other hand, I think it subtly changes things, and for some people, it presents a huge issue. And I don't want to say it's bad. I just say something's changed, and those are two areas I would look.
Absolutely. That makes a lot of sense. It absolutely makes a lot of sense. That's true. One question for you. Is there anything new in the research in terms of diagnostics for food sensitivity testing? I say this because, my best friend is an allergist immunologist.
Okay.
Trained at National Jewish, Johns Hopkins, highly academic.
Yes.
It took me a long time to teach her about leaky gut. She didn't believe in it for the longest time. And I said, listen, it's just the layman's term for intestinal permeability issues. It is real, right? It is real.
Absolutely.
But they don't validate IgG testing, in terms of the National Allergy Association, right? They don't validate it.
No, they do not.
And you clearly mentioned, Dr. Dorval, the three different types of food sensitivity testing, and they're very different, right? They're very different.
Very different.
Very different. And so it's not uncommon that in my practice, as part of just kind of trying to tease out which labs I want to work with, on the same patient, I have tested food sensitivity testing using one lab versus another lab and gotten very different results. I've gotten more consistency with a particular lab, and that's why I continue to use KBMO, right? But I've gotten very different results. And so the question is, what do we tell our patients, or what do we tell people out there when they are, talking to their allergist? And also, we recognize that food sensitivity plays a huge role in IBS patients, but is there anything new coming out of the research that can at least allow for some, ability to standardize the testing and have reliable results across the board?
Yeah. Well, it's interesting. I mean, again, we make our own tests, manufacture them, and we do our own testing in our own CLIA certified lab. So we standardize our tests. Every single lot must have a certain reactivity with the standards that we use. And then when we transfer them to clinical, they repeat the validation and they must replicate the work that we do. So having said that, standardization is always an issue. And the fact that a lot of national, immunology organizations, still think IgG testing is somewhat questionable. Here's my response.
Yes.
My background is immunology. I came out of immune complexes and activation of complement. And on one hand, you can say proof positive that immune complexes that activate complement generate inflammation, whether you have a kidney disease, whether you have a graft versus host transplant, whether you have a viral disease, whether you have a bacterial disease. So having said that, in all those areas that immune complexes activate complement and generate inflammation, on the other hand, how can you say if you form immune complexes with food and those immune complexes activate complement, that they won't be a problem? Right. So to me, it's a little, I had this discussion with a fellow from Harvard, actually, and he conceded a point that which is obvious. You can't have it both ways. Right. Either immune complexes that activate complement are good or they're bad. And whether it's a food antigen or a viral antigen, it doesn't make any difference. Absolutely. It's the C3A, the C5A, and the lysis of cells, which occurs from complement, that generates the inflammation. And there's the crux of it. Now, what's coming out that's very interesting in that area, I think, in research, and the tie-in may be a little bit obscure, but hopefully I'll make it relevant, is the study of the microbiome and the microbiota in the gut, and this gut-brain axis, which people are finally starting to say, hey, look, this is actually real. So what we've realized is that the microbiome, the microbiota in the gut, they process foods and antigens by enzymes, and they prevent damage to the gut lining. And when they don't do that, or they've been damaged, maybe another infection, maybe cancer, maybe diabetes, where people have damaged the microbiome, these people have a propensity to have leaky gut.
Right.
Zonulin is high, a protein, and they end up with a wide variety of symptoms that are associated with food sensitivities. So it's coming out of this study of the microbiome that's really showing that they're key to prevent leaky gut. And if they don't, then antigens get through the gut where they shouldn't be. Antibodies and immune complexes are being formed, and then they do their dirty work and cause the inflammation. So that's coming out now, and I think it's a pretty exciting area today. 10 years ago, 15 years ago, if you would have said this, they would have said you're ready for retirement. But but it's really it's coming to the fore, and I think
there's a lot of evidence. There's so much scientific data. You just have to search, and sometimes you feel that the physicians or the practitioners who are not reading anymore, not searching anymore, not going into PubMed, are just not advancing, right? And our patients are advancing. Our patients are educating themselves. They are coming in and asking me whether I'm doing the zonulin test with the KBMO fit test. So it's important. I think it would be absolutely interesting to do a study actually on patients with chronic liver disease. I recently did a presentation on the gut-liver axis, right? It's amazing to know that, a lot of patients with chronic liver disease, especially cirrhosis, about 40 to 50% of those patients have bacterial overgrowth and gut, right? So it would actually be interesting to do a small study on that population and look to see what their food sensitivity panels look like. Because I think that would show a lot of reaction and sort of confirm, because they live chronically, and maybe help guide us in terms of what foods they should be avoiding to help heal their guts. Because at the end of the day, it's about food, like you said, it's about food.
Right, and the two clinical studies that we've done, again, the retrospective study as well as the prospective study, show that this, in just a nutshell, if you test people when they come in the door and you get their symptomology, and then you wait 10 months, their antibody titers go down. So they had lots of very high reactivities, very high antibody titer, and a lot of symptoms. When you test them 10 months later, their antibody titers and immune complexes have gone down. And then when you ask them, okay, what are your symptoms? Their symptoms have lessened significantly because the FIT test can identify foods which cause inflammation. And if you get them out of the diet, you feel better. Now, nobody's going to drop the crutches and walk you. This is not a cure. But what it does is it offers a guide to patients so that they can control their diet. And if they do, they can use that information to feel better. And that's what we're seeing. And that's what two clinical studies that we have done shown. And I don't think any other test out there has an IRB approved clinical study for food sensitivity that can make that claim.
Excellent. That's excellent. So we talked about, we can wrap it up now, because I think we've got a lot of great information, but I want our community, our natural gut relief group, which is our private Facebook group, to really take home some pearls here. We talked about probably not testing the person, someone who does not have any symptoms, right? We don't see the benefit there.
I agree.
We talked about the difference between a food allergy, which is an IgE immune-mediated immediate reaction, right? So this is like you eat peanuts and you break up in hives and you need an EpiPen. That's different. What we're talking about this evening is food sensitivity, right? So which patient or what symptoms would you suggest that that person considers food sensitivity testing for? Like, what symptoms would you think are higher on the list that could suggest food sensitivity and should guide them towards food sensitivity testing?
That another excellent pertinent question is a patient that comes in, and what we see is bowel problems. Somebody that has an irritable bowel, the diarrhea, pain, bloating, that's a big one. The other big one that we see that's very common is skin problems.
Mm-hmm.
Skin problems. They come in, they have eczema, or they have hives or something like that, and they just can't seem to get rid of them. They know they're associated with food, but they can't put their finger on it. So that's a two good group. Another group that we're seeing is, more chronic fatigue people.
I see.
They got general malaise. They don't know exactly what's wrong. They just don't feel right. So they're searching for an answer. So that's a big group. And then I would say the third would be more anxiety, mood disorders, depression, that sort of thing. And we know now from the microbiome and the gut-brain axis and serotonin and all the various neurotransmitters that are produced by the gut or modified by the gut, that if the microbiome is screwed up, that it communicates with the brain and may generate these anxiety disorders that's all wrapped up and related to food sensitivities. So that's a really big group today.
Absolutely. That's a really big group. That's a huge group.
Huge group.
And I mean, some of it is because IgG presents all over. So you can have symptoms, right? This immune complex activation can happen anywhere in the body. Brain, skin, gut, anywhere, joints, anywhere throughout the body. So Dr. Dorval, this was great information.
Thank you.
A lot of pearls, a lot of take-home points. I want to see if anyone's got any questions, any questions we can answer quickly. I have somebody mentioning their inflammation and pain on their body, unable to tolerate a rainbow variety of foods, and concerned that maybe some herbs, right?
Oh.
Natural herbs and supplements may be causing reactions, correct?
Oh, absolutely. That is probably the biggest thing we're seeing today. Everybody, almost everybody that I'm talking to, supplements, they're taking all kinds of herbal supplements, power bars, shakes, all these things. And they'll say, well, I don't consume that. But you say, well, let's take a look at the supplements and oh, okay. Well, yeah. And they take 2 or 3 capsules in the morning, 2 or 3 at night of highly concentrated products. And it's like, they're touted as healthful, but to some people, I don't think they're quite so helpful. So supplements is something, and spices are another group that you got to watch out for. They contain a lot of phenyl compounds, and phenyl compounds not only induce allergy, but they're also important in food sensitivity.
I see. That is really, really important, right? A lot of people are taking supplements out there, self-dosing, and sometimes even prescribed, where people are taking up to 40 pills. It's too much.
Yeah, it's absurd.
It's too much. And at the end of the day, I think the solution goes back to food, healthy eating, avoiding the process, going back to wholesome foods, right? Wholesome foods.
I agree.
Dr. Dorval, thank you so much. This was a wonderful Back to Basics. We learned a tremendous amount of information, and we thank KBMO Diagnostics for the fit test, because we've been using it in practice for a while, and it is helpful to a lot of our patients, right? It is really helpful.
Very good test.
And I really like the nutritional components. It always comes with a nutritional handout, sort of what to eat, the stepwise process, and how to reincorporate foods. A lot of information about all the different groups of foods to avoid. Very, very well done. Thank you very much, Doctor.
Well, we appreciate that, and we look forward to serving the clinical community in the future. And I hope to come back sometime in the future.
Absolutely.
And speak with your group again.
All right. Thank you very much. And everyone, this was Back to Basics. Have a wonderful evening, and we will reconnect next Thursday.
Great. A pleasure.
Bye-bye.
Great. Thank you.
Bye.